So today we're going to talk about the delta-delta gap, which is often a particularly confusing area for most people, including myself. So I'll try and explain it to the best of my abilities, as limited as they are. Okay, so we talked before about what causes the anion gap. It's unmeasured anions. When you have an acid, either an endogenous acid like a keto acid or lactic acid, or an exogenous acid, you have a proton and then you have the anion, whatever, depending on what kind of an acid it is. And normally, what's the major buffering system for acid in the body?
Bicarb.
Bicarb. So normally you have sodium bicarb, and this reaction goes to H plus HCO3, and then you have sodium and then the anion. So the H plus HCO3 goes to what?
It's
H2O plus CO2. Okay, so when you think about an anion gap, if you have either an increase in an endogenous acid like lactate or DKA, or an exogenous acid, for every molecule or mole of the acid, it's going to combine with the same amount of bicarb, right? And that's going to change your anion gap, okay? So you're going to be left with this. So normally there should be a one-to-one, you would think there would be a one-to-one relationship for every unit of acid, whatever units you're using. The bicarb should change by the same amount, right, according to this equation. And if the only buffering mechanism that we had in the body was bicarb in the blood, that would probably be true. But that's not the case, because there are other buffering mechanisms besides bicarbonate. So do you know what any of those are? Well, other than things within the blood, is there any way to get rid of acid? Other than combining with something else in the blood, like bicarb, a buffer.
Excreting it with urine.
Okay, so excreting it in the urine is one way to get rid of it. Like in ketoacidosis, you excrete the acids in the urine, right? And what's another way? There's one other major buffering mechanism.
Oh, respiratory?
Not respiratory.
Proton exchange, like H plus and K plus?
Kind of, but where does that exchange take place? It's intracellular. So a lot of the buffering takes place in the cells. So the acid goes into the cells and they're buffered intracellularly, not just extracellularly in the vascular compartment. So there's really three different ways to buffer acids, right? Okay,
Bone.
so what?
Bone? Is it bone? You were talking about
Bone?
Yeah.
I guess some could go in the bone. I don't know how long that takes. I'm not sure. So in a perfect world, if it was only in the vascular compartment, you would have a one-to-one relationship between a change in the anion gap and a change in the bicarb. So for every increase in the anion gap of 1, the bicarb should go down by 1, right? Because of these other mechanisms, that's not strictly true, okay? All right, but it turns out that for ketoacidosis, when you take into account the intracellular buffering, the bicarbonate, and the excretion of ketoacids in the urine, it does turn out to be fortuitously a one-to-one relationship, okay, for ketoacidosis. For lactic acidosis, it turns out to be a 1.6 to 1 relationship, okay? And in general, any type of increased, endogenous or exogenous acid, it should be between 1 and 2, okay? So the ratio between the delta anion gap and the change in bicarbonate, the change in anion gap and the change in bicarbonate should be somewhere between 1 to 2. If all you have is an increased gap type acidosis. Now if you have a non-anion gap acidosis, in addition to an anion gap acidosis, what's going to happen? So the bicarb will drop further than you would expect from the increased gap acidosis alone, right? Which means this difference becomes larger because you have a bigger drop. And what happens to this fraction? It gets smaller, right? The denominator gets bigger, so the fraction gets smaller, so it's less than 1. So if you have a non-anion gap acidosis superimposed on the increased gap acidosis, this ratio is less than 1. On the other hand, if you have a metabolic alkalosis, in addition to an increased gap acidosis, this bicarb will be higher. The bicarb will be higher than you expect. This change will be smaller. The bicarb won't drop as much, so the delta bicarbonate will be smaller, and that will make the fraction bigger. So if you have a metabolic alkalosis superimposed, then this ratio is going to be greater than 2. Okay?
Which one you said is the ratio between 1.6 is to 1?
This is a lactic acidosis.
But lactic acidosis.
Okay, so I'm going to give you some examples to show you how some of this works. Okay? So I'm going to erase this. You got it all? Are you guys with me so far?
Yes.
You sure?
Yeah.
Okay, I have it all in my little phone here, so I've got to say, have these examples worked out. Okay, so you have a 27-year-old with diabetes who comes in and they have a sodium of 140, a potassium 7, chloride of 105, bicarbonate of 6, pH 7.10, PaCO2 20, glucose 800, ketones in the urine 4+. All right, so first thing you want to figure out is what's the acid-base disturbance, okay? So we're going to go back to where we started, and which one of you guys wants to figure that out? What's the acid-base disturbance? Okay, so you have a primary metabolic acidosis. So you look and you see the pH is, it's acidemia. You have a low bicarb, which goes along with a metabolic acidosis, and a low CO2, PCO2, which goes along with what? Respiratory alkalosis. And so the question is this normal compensation or not? The next step, right? So how do you figure that out?
The change in PCO2
Okay, good.
should be equal to the quotient, which is 1.2.
Okay, times the bicarb times the
Yeah.
factor, which is 1.2 for a primary metabolic acidosis. Right?
Yes.
And what's the change in bicarb? 18 times 1.2. So that is 21.6. Right? So the change in PCO2 should be about 21, and that would give you a PCO2 of 19, and it's 20. So it's pretty close. So what would you say? It's appropriate compensation. So you have a primary metabolic acidosis with appropriate respiratory compensation. Okay, so what's the next step? You have a primary metabolic acidosis. What's the next step in the evaluation? What do you want to look at next? Anion gap. Okay, so what's the anion gap? How do you calculate it in this patient?
140
So it's the sodium, which is 140.
plus K potassium.
No, we're not going to use potassium, right?
Oh,
So
no, yeah.
that's the old method. Okay, so we're going to ignore the potassium for now. So 140 what? Minus the bicarb plus the chloride. So you have the chloride, 105 plus 6. Chloride, bicarb, sodium. So you have 111, 140 minus 111 is 29. So you have an anion gap of 29, right? Okay, so you've got an increased, is that an increased gap? Yeah, so you have an increased anion gap acidosis. And what's the next question?
Why?
Well, that's one question, which we'll get to at the end. But you're not done, because what did we just talk about? The delta gap, right? So you want to figure that out. Now that you have a primary metabolic acidosis, you want to figure out with an increased anion gap. And the next question is there another superimposed process, either a non-anion gap acidosis or a metabolic alkalosis? So you can have a triple disorder. You can have 3 things going on. You could have 4 things technically going on. So what's the delta anion gap for this patient? So the delta anion gap, the change in anion gap from normal is what? What's a normal anion gap? I told you, yeah, 10 to 12, so let's use 10. So 10, if you use 10 as the normal gap, 29 minus 10 is what? 19. Okay. And the delta gap is the ratio between the delta anion gap and the delta bicarb. What's the delta bicarb? It's the change in bicarb from normal. 18. So you've got 19 over 18, which is what, about 1, approximately. Okay? So what does that mean? I said if it's between 1 and 2, there's not another process. It's just a pure primary increased anion gap acidosis. And in this case, what kind of acidosis is that? Ketoacidosis. And I told you that the ratio is normally about 1 in ketoacidosis. So that's exactly what we have here. Okay? So that's kind of how you use it. Now I'm going to go through a more complicated problem. Okay? You with me? You had a question.
I was just wondering if there was a superimposed metabolic alkalosis, we wouldn't find, like that could be metabolic alkalosis plus the respiratory alkalosis is sufficiently compensating for, because I feel like when we're figuring out originally if it's compensated appropriately, that's including metabolic alkalosis and respiratory alkalosis together. Do you have any?
I do. I think this will help you sort it out. Let me do the next question, or the next problem, and maybe we'll see. Because the respiratory compensation is going to be, I mean, it's either going to be complete or it's not going to be appropriately compensated, right, when you figure that out in that example. So if it's not completely compensated, you're only really looking at the respiratory part of it at that point. There still could be a superimposed metabolic alkalosis there.
And that you would see in the delta gap.
Right. So let's do the next problem, and I think you'll see how it works. We can get back to this. Okay, so this next example is a 56-year-old with female with severe nausea and vomiting times 5 days. Okay, that's the history. So the patient comes into the emergency room with this history. You do your physical exam, and you find out that they have an increased heart rate, tachycardic. They have a low blood pressure. They're hypotensive. They have decreased skin turgor, dry mucous membranes. Okay? All right. These are the labs. The sodium is 140. My glasses back on, unfortunately. Potassium is 3.4. The chloride is 77. The bicarb is 9. The pH is 7.23. PCO2 of 22. Ketones in the urine are trace. Creatinine is 2.1. Okay, so first, what's the major acid-base disturbance? What do you do? So you have a pH of 7.23. So you have an
acidosis.
acidemia.
Acidemia.
So at least one of the processes is acidosis. And what kind of acidosis is it?
It's metabolic.
Okay, so you have a primary metabolic acidosis. Okay. And what about, is it appropriately compensated or not?
That the compensation for metabolic acidosis would be respiratory, so change in the CO2, which is 12.
Change in bicarb times that.
That is 1.2.
Yeah, I'm going to erase this up here so I'm already. So you have change in PCO2 equals a change in bicarb times the factor of 1.2 for metabolic acidosis. And what's the change in bicarb?
It's
From normal? 15, right? Times 1.2, so that's 18, right? And that's exactly right, right? 40 minus 18 is 22, so you have an appropriately compensated metabolic acidosis, primary metabolic acidosis with appropriate respiratory compensation, okay? But you're not done. So even though it's compensated, this gets to your question, you're not done, right? So you do have a respiratory alkalosis in a sense because it's compensating appropriately, and everything works out perfectly, right? But you haven't done the delta-delta gap yet because there could still be something else wrong. So you do the delta-delta gap. So what's the delta? So what is the anion gap? Is the next question, right?
40 minus 86.
140 minus 86. Wow, it's a big number, isn't it?
T4.
140 minus 86, 77 plus 9. Okay, so what is it? 54. Very large anion gap, right? Okay, so this is the anion gap. And what's the delta anion gap?
It was 44.
It's 44. Okay. And what is the delta anion gap over the delta bicarb, or the delta-delta? So you have 44 over, what's the delta bicarb?
15.
15. So what's this ratio?
Greater than
It's
2.
like almost 3 to 1, right?
Yeah.
So 3 to 1 is greater than 2. So what does that tell you?
That means that there's a superimposed metabolic alkalosis.
Correct, a superimposed metabolic alkalosis. Okay, so because technically the bicarb is actually much higher than you would expect for this degree of acidosis. So you have, so the bottom line is you have a primary metabolic acidosis with appropriate respiratory compensation plus a primary metabolic alkalosis. Which intuitively doesn't make sense, right? Oh, yeah, how could you have an acidosis and alkalosis at the same time? You do, okay? Metabolic. Okay, so the next question is always, well, what's causing that, right? What's causing the increased anion gap metabolic acidosis in this patient, do you think?
Starvation, ketosis?
No. Well, first of all, it's a pretty severe acidosis, right? Bicarb's down at 9, and that's probably falsely elevated by the metabolic alkalosis that you have. So it's really severe. You don't get, starvation ketosis doesn't cause that severe an acidosis. Usually it doesn't get, the bicarb doesn't usually get below like 15 or even 18. So it's usually mild.
Lactic acidosis.
Okay, from what? Lactic
From her
acidosis.
hypotension.
From the hypotension. So the patient, remember, was hypotensive, was in shock. So the lactic acidosis is a big part of it. What else is part of it?
Uremia could be there.
Yeah, so there's some renal failure too. I don't know if this is acute or chronic, but that's probably contributing to it as well. So you have 2 reasons for the patient to have a metabolic, increased gap metabolic acidosis. And what's causing the alkalosis, the metabolic alkalosis? Vomiting. So the patient's been vomiting for 5 days. Okay, so not only are they volume depleted and contracted, but they've been losing acid through vomiting, right? So what's the treatment for this patient? Fluid. What kind of fluid?
Normal saline.
Normal saline, right? It's going to be a chloride responsive metabolic alkalosis, right? Based on the history, which is caused by nausea and vomiting, causes a chloride responsive metabolic alkalosis. If you were to measure the chloride in her urine, what would it be? It would be low, less than 20, okay? So you would give saline as your fluid of choice, and you give a ton of saline because this patient is really volume depleted, right? So you do that, you give a lot of saline, you give a lot of sodium and chloride, and you volume expand them and get their blood pressure up, and what happens to the lactic acidosis? Clears, right? Because you restored perfusion now. And what happens to the renal dysfunction? Probably improves too, hopefully. So what's going to happen? So that increased gap acidosis is now gone, right? So what's left? A metabolic alkalosis. And how bad a metabolic alkalosis do you think it's going to be? It's going to be really bad. Okay, you're going to be left with a very severe metabolic alkalosis. And if you don't anticipate that, you're going to have real problems. So you could anticipate that because you figured all this out, that she's got these 2 different processes, and you're only treating one of them with the saline. Okay? So you need to be aware that this patient's going to develop a severe alkalosis. And remember, the body doesn't really handle alkalosis nearly as well as it handles acidosis. Causes more arrhythmias, causes a lot more problems than acid. Your whole body is designed, everybody's always worried about acidosis because of all these things that happen. When bad things happen, you develop an acidosis, but your body is designed, really designed, to handle acidosis because of that. But it's not really designed well to handle alkalosis. So you really don't have the same kind of mechanisms to handle alkalosis like you do acidosis. You don't have that buffering for acidosis. You don't have that system to create acid. It's not like, at least not to that degree, right? So you need to be aware that that's going to become a problem, and people can get into all sorts of trouble if it's bad enough, and this is going to have a really severe alkalosis. Okay?
So then what would you give with the normal sample?
You know, you might have to give acid at some point, you know, which you could give ammonium chloride or some other acid if it's bad enough.
So when you're treating someone with such a severe acid-base problem, are you constantly monitoring ABGs to make sure that you don't like?
If it's this kind of problem, you should be, you know, that's exactly it. You should be monitoring it to see what's going on. You don't just write the order for saline and come back tomorrow. You need to keep rechecking. And that's pretty much true in critical care in general. It's all about monitoring. That's why they're in the ICU. That's why they get the nursing monitoring, the electronic monitoring, and you need to be doing metabolic monitoring, you know, frequently on these patients. And if you do that, you're not going to get in trouble. And if you don't do that, you will get in trouble. And that's why we're always, you know, all the attendings are always harping on you. Did you recheck this? Did you repeat that? You know, oh no, I just ordered the potassium and I didn't order another level later on. Well, how do you know you gave enough, or how many do you know you didn't give too much? The only way to do it is to continuously monitor. You know, as you get more experience, you kind of get a feel for how frequently that monitoring needs to be. But, you know, the less sure you are of what's going on, the more frequent the monitoring should be. That's the bottom line. Because if you continuously monitor, you won't get into trouble. And if you don't monitor, you're going to get into lots of trouble. The patient's going to get into lots of trouble. Okay. Those are the only two examples I have. So I don't know if you have any other questions about the delta gap.
Do you still have to do the delta gap
Delta.
if they're inappropriately compensated?
If
or do you only do that if they're appropriately compensated?
No, you do it any time you have an increased anion gap acidosis. You should do a delta. Okay. Increased gap metabolic acidosis. Okay. All right. We good?